Jenny is a 35-year-old real estate agent who has been experiencing pain in her second web space for 1 month. Jenny has previously seen a podiatrist and was sent off for an ultrasound after her podiatrist performed the Mulder's click and squeeze test, which suggested a Morton's neuroma. The ultrasound confirmed a Morton's neuroma in the second web space and also found an intermetatarsal bursitis. Jenny has no other medical history. She is taking ibuprofen to help reduce her pain levels, and her only allergy is to sports tape. And lastly, Jenny wears high heels to work every day. Morton's neuroma is an entrapment, irritation and swelling of the interdigital nerve, often as a result of compression of the nerve against the distal end of the transverse metatarsal ligament during dorsiflexion of the toes. It is most common between the third and fourth web space, however it can occur between the second and third web space. Common causes include narrow toe box footwear, hyperextension of the toes in high-heeled shoes, deviation of the toes and inflammation of the intermetatarsal bursa, which is termed bursitis. Symptoms of Morton's neuroma include feeling as if you're standing on a pebble in your shoes, a burning pain in the ball of your foot that may radiate into the toes, and tingling or numbness in the toes. Signs and symptoms of an intermetatarsal bursitis include swelling and pain and tenderness over the location of the bursa. Jenny has previously tried a number of treatment strategies, including a metdome and orthotics. However, they were not successful as Jenny is still in quite a lot of pain. Jenny would like to see what else can be done to treat the Morton's neuroma and intermetatarsal bursitis.
Jenny arrives at the podiatrist with concerns over corticosteroid injections. She says many people have told her that it will do more harm than good. She's worried the effect is to mask the pain and not treat the problem. The podiatrist reassures Jenny that many people have opinions on corticosteroids without fully understanding how they work. Injecting a corticosteroid into bursitis will decrease the inflammation and fluid collection that has been a major factor of Jenny's pain. Injecting the neuroma will help reduce tissue thickening, thus reducing pain. The podiatrist preferences betamethasone as the injection of choice due to its high solubility, meaning the risk of fatty tissue atrophy is reduced, as well as connective tissue degradation. Jenny is worried the procedure will hurt. However, the podiatrist reassures her that combining betamethasone and local anaesthetic will immediately block the nerve, providing short-term pain relief and allow her to diagnostically locate the area of pain. Jenny feels confident in her decision, and the podiatrist prepares the site for injection by marking the met heads and the nerve affected. The injection enters from the dorsal aspect of the foot and is inserted into the neuroma first. After injecting the neuroma, the podiatrist raises the needle dorsally to the bursitis and injects. Instant relief will be short-lived once the local anaesthetic has worn off. Therefore, it is important for Jenny to be aware of the pain increasing hours after the injection. Jenny is counselled from the podiatrist that multiple injections may be required and results will diminish over time. Jenny leaves the clinic feeling hopeful and slightly numb. Although she heard the doctor's precaution of increased pain, she's pretty sure this won't happen to her.
3 days after receiving the injection, Jenny returned to the clinic complaining of pain on the same foot, which was severe than her previous pain. The injection site looked slightly swollen and red. She rated the pain 4 scores higher based on visual analog scale than she rated previously as part of her initial consultation. We suspected this increasing pain is related to a steroid flare. Steroid flare is a local reaction due to development of steroid crystals in the soft tissue or in the synovial space. In some patients, it can be presented with erythema and swelling. It is one of the most common complications occurring following a steroid injection and may last for 12 to 72 hours. To manage her pain resulting of flare-up, podiatrists may recommend rest and using ice to reduce the inflammation. Medications can be used such as ibuprofen and paracetamol. Also, to reduce the risk of cortisone flare, many clinicians use injectable that combine short-acting compounds with long-acting suspensions like betamethasone sodium phosphate and acetate suspension, because short-acting agents are less irritating and less likely to cause a post-injection flare, and longer-acting, as the name suggested, remains longer in the tissue. So when using a combination, podiatrists can obtain a beneficial effect of both types of preparations. However, the research studies have investigated the efficacy or duration of action of the various agents in the joint or soft tissues are few. In addition, mixing the corticosteroid preparation with a local anesthetic is also a common practice for avoiding the injection of a highly concentrated suspension into a single area. The anesthetic provides early relief of symptoms and helps confirm the diagnosis.